Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This podcast provides observational and commentaries on the JCO article Osteonecrosis of the Jaw and Oral Health-Related Quality of Life Following Adjuvant Zoledronic Acid, and Azure Subprotocol by Emma Rathbone et al. My name is Charles Shapiro, and I'm a professor of medicine, breast research program leader at the James Cancer Hospital and Soloff Research Institute, and the Ohio State University Comprehensive Cancer Center located in Columbus, Ohio, United States. I'm a medical oncologist and my specialty is breast cancer. Bisphosphonate-related osteonecrosis of the jaw is a rare side effect, primarily of intravenous zoledronic acid and more recently subcutaneous denosumab. The definition of bisphosphonate-related osteonecrosis is the presence of necrotic bone for greater than 6 weeks in an area of the oral cavity normally covered by mucosa, prior or current bisphosphonate use, and no prior history of radiation to the head and neck. The risks of osteonecrosis increase with more frequent scheduling, for example, monthly doses of IV zoledronic acid as opposed to every 6 months, and prolonged durations of administration in excess of 2 years. The major risk factors for osteonecrosis is dental extractions or procedures that expose bone during treatment with these drugs. Principally, this led to the recommendation that prior to initiating bisphosphonates, a dental evaluation and, if needed, dental work be completed before starting these drugs. Small, non-randomized cohort studies suggest that the incidence of osteonecrosis is decreased following dental screening prior to initiating these drugs. Importantly, there was no evidence that routine dental health maintenance increased the risk of osteonecrosis, and patients should be encouraged to have routine dental care when they receive these drugs. The precise mechanism of osteonecrosis, why it's confined to the jaw, predisposing risk factors other than dental extractions, the optimal treatments, and more importantly, both the short and long-term outcomes and health-related quality of life of patients that develop osteonecrosis is largely unknown. Some, but not all, recent studies suggest that the genetic polymorphisms in genes related to bone metabolism, collagen, or aromatase may predispose an individual to osteonecrosis. In addition, recent small studies from patients either seen in a dental clinic or in a cancer clinic suggest that awareness and education about osteonecrosis is sorely lacking. With this as background, Rathbone and colleagues, on behalf of the Azure investigators, report the incidence and outcomes of osteonecrosis in a prospective randomized controlled trial of IV zoledronic acid in over 3,000 women with localized stage breast cancer receiving adjuvant systemic therapy. They also assessed oral health-related quality of life in a small subset. In the Azure trial, the primary endpoint was disease-free survival, and the overall results showed there was no difference in disease-free survival between zoledronic acid group and control group. In the Azure trial, 26 women developed osteonecrosis, and the overall cumulative incidence rate of osteonecrosis at 9 years was 2.1%. At 3 years is about 1.1%, similar to the cumulative rate of osteonecrosis of 1.4% in 3 years in women treated with zoledronic acid with skeletal metastasis. The 1.1% value was about fourfold higher than that reported in a meta-analysis of less frequently scheduled zoledronic acid to lessen bone loss in early-stage breast cancer. The schedule of zoledronic acid in the Azure trial was intensive, with zoledronic acid administered every 3 to 4 weeks for 6 doses, then every 3 to 6 months for 5 years, or a total of 19 doses. The 19 doses approximated the standard 24 monthly zoledronic acid doses typically used in women with breast cancer with skeletal metastasis. It is interesting to note that in the Austrian Breast Cancer Study Group Trial 12, in which 1,800 premenopausal women received goserelin and either tamoxifen or anastrozole, with or without zoledronic acid, women treated with adjuvant zoledronic acid had reduced risk of local recurrence, bone and distant metastasis with a highly significant p-value of 0.009. The schedule of zoledronic acid in this trial was 1 dose every 6 months for 3 years, or a total of 6 doses, and there were no reports of osteonecrosis with a median follow-up of 5 years. The outcome of the 26 women that developed osteonecrosis in Azure was reported as completely recovered and improving for 35 and 19% of the patients, respectively, and recovered with sequela and present and unchanged for 12 and 31%, respectively. It is unfortunate that precise definitions were not provided for these descriptors, nor were the details of the specific treatments of osteonecrosis provided. The optimal treatment of osteonecrosis is not defined, and in a recent review, healing of osteonecrosis associated with medical, surgical debridement, or surgical flap annular resection was 18%, 17%, and 46%, respectively. However, these data were from non-randomized, retrospective, and cohort studies subject to patient selection and other biases. The quality of life component in the Azure trial was a one-time assessment of quality of life 5 years after randomization, measured in a subset of trial participants using the oral health-related profile questionnaire, which is validated in a non-cancer population. The results showed no difference in the domains of oral health-related quality of life in a small subset of women respondents randomized to zoledronic acid or control. These results may provide some reassurance that 5 years down the road, patients that received zoledronic acid don't have detectable impact on their health-related oral quality of life. However, the authors themselves acknowledge that this one-time retrospective assessment of oral health-related quality of life is a weakness of their study, and in my view, limits drawing any definitive conclusions. There are few data assessing the quality of life in women with osteonecrosis. In a non-randomized comparison of 42 women with metastatic breast cancer receiving intravenous bisphosphonates, patients who did develop and did not develop osteonecrosis, quality of life was statistically significantly worse in the domains of pain, swallowing, speech, social eating, social contact, and several others for those with osteonecrosis. Nearly 50% of the women who developed osteonecrosis in Azure were either characterized as recurrence with sequela or unchanged at last follow-up. What happened to these women and how much impact and interference osteonecrosis is having on their daily lives is unknown. Additional information regarding osteonecrosis is expected from 2 large cooperative group trials using zoledronic acid. CLGB in over 1,800 patients with metastatic breast, prostate, and multiple myeloma is designed to determine whether every 3-month IV zoledronic acid is non-inferior to the standard monthly schedule with a primary endpoint of incidence of skeletal-related events and the secondary endpoints of incidence of osteonecrosis, renal dysfunction, and pharmacogenomics using whole genome-wide analysis. In the other trial, which is the SWOG trial, over 3,000 women with early-stage breast cancer randomized to 2 oral bisphosphonates, ibandronate, and clogenate administered for 3 years, an intensive schedule of zoledronic acid, 6 monthly doses followed by every 3-month dosing for 30 months, or a total of 16 doses. The primary endpoints are disease-free survival, overall survival, and adverse events in the SWOG trial. Results are expected in 2014 for the CLGB trial and 2015 for the SWOG trial. In the 10 years since osteonecrosis was first reported, There are literally hundreds, if not over 1,000 papers appearing in the dental and medical literature on the topic. The incidence of osteonecrosis is likely decreasing with increased awareness and definition of the disease, disseminating recommendations for dental screening, and limiting the schedule and duration of monthly treatments. When IV zoledronic acid is used for cancer treatment-related bone loss, the incidence of osteonecrosis is very low, about 0.25%, and lower still with the use of oral bisphosphonates. Likewise, the 1 to 1.5% incidence of osteonecrosis with 24 monthly zoledronic acid doses in treating skeletal metastasis in women with breast cancer is acceptable in most cases. If the results of CLGB 70604 indeed show that less frequent dosing of zoledronic acid is non-inferior to the standard monthly dosing, this will also likely increase the lower incidence of osteonecrosis and other toxicities. However, the use of IV zoledronic acid to improve patient outcomes is a work in progress, and the results from the SWOG trial should provide additional data. Overall, the Azura trial results showed that zoledronic acid on an intensive schedule did not improve disease-free or overall survival, and therefore the 2% total cumulative incidence of osteonecrosis, although low, is clearly not acceptable. Whether there is a subpopulation of postmenopausal women in which treatment with zoledronic acid, as reported in the Azura trial, or oral clodronate, as reported in the NACBP B34 trial, improves disease-free survival remains to be verified in subsequent trials. Finally, Phase 3 trials are addressing the role of denosumab to improve clinical outcomes in women with early-stage breast cancer are ongoing. This concludes this podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.